So, hello everybody to this year's late summer school. On behalf of Sono4U Graz, we want to welcome all of you who are here in Graz, our partner universities, and all the people who are following us via the live stream. We are Lorena and Samuel from Sono4U Graz, and we are very happy to accompany you through these 3 days to share organizational details and to introduce exciting speakers. Especially, we would like to welcome our guests of honor. She is an expert in musculoskeletal imaging and a specialist in radiology. A warm welcome to Dr. Jasminka Igrec. He's a mountain rescuer, the regional physician of the Steirische Bergrettung, and a specialist in anesthesiology and intensive care medicine here at the LKH Graz. Please welcome Dr. Stefan Heschel. Then from our partners, we have here for Midas, Dr. Christian Schantl, and from the Flick Förderungsstiftung, Eva Maria Konrad Ischep. Hello. As a vice rector for studies and teaching, she is involved in our education and always has some open ear for our concerns and projects by Sono4U Graz. We are very happy for that. We would now like to ask you to give us a short introduction speak. Please welcome Vice Rector Dr. Sabine Vogel.
Dear students, dear guests, on behalf of the entire Rectorate of the Medical University of Graz, I'd like to welcome you at this really special, outstanding event. The Late Summer School for Ultrasound realized by Sono4U, and I want to pick out four persons: Georg Erath, Samuel Peintner, Jakob Schwarzel, and Anna Traninger. They are the heads of this project this year. It's again an opportunity for you to join lectures, to participate at hands-on workshops. Hands-on is very important in that case, and attend repetition lessons. And this year again, there is a live stream, so a warm welcome to everyone who can hear and watch us right now. When I prepared these words of welcome, I had to think about a song. It's a very old one. It's a jazz song. You might know it as well. It was recorded in 1959 at the first time, and there has been some other versions since that. The song is by Dinah Washington, and it is called "What a Difference a Day Makes." I had to think about it because what a difference a year makes for this event. Well, let's look us back. Not much has changed about the pandemic and hygiene rules, I have to say, except that vaccination is available. It was developed in a short time. And to take responsibility and fight this crisis, we should all get vaccinated. This is why I wear this bracelet. But what has really changed since last year? Yeah, there are a few aspects I want to mention. Last year, I stood here and told you that our commission for the curriculum of the human medicine curriculum is working on a specific part for including sonography at several stages of the curriculum. Today, I can tell you this is not only a working plan anymore, but in the meantime, they already established that for the models for internal medicine and as well for model for surgery. And the next step is to realize or to implement sonography teaching units for emergency ultrasound. In best case, in summer term, we expect that. So you can see it is an ongoing process focused on learning outcomes for our students. Well, what else has changed this year? Let's think about Sono4U themselves. They have been nominated for the National Award for Excellence in Teaching, the so-called Ars Docendi. And there are 5 categories, nearly 200 submissions they got this year, and they have been selected for the shortlist, which contains the 15 best projects. Well, Sono4U, Graz, the flipped classroom abdomen sonography was the honored project. This is really amazing. You can really be proud about that. And again, congratulations from my side to Esther Leimer and Georg Erhard and the team. This is really inspiring for us at the Medical University, for the students, we hope. And this supports our new label we are implementing actually at the moment. It calls Pioneering Minds, Research and Education for Patients' Health and Well-being. And Sono4U, you are such pioneering minds. Well, what can we see in the next days? So, the ongoing thinking about those tunes, what a difference a day makes, let's say not a day, but 48 hours. You will hear some great lectures, you will have those hands-on workshops, and a lot of peer teaching units. Peer-to-peer is a great effort, I know, but great results as well in internalizing learning objectives. And the last line of this song says the following. I know, meant is something completely different, but it says, what a difference a day makes, 24 little hours, and the difference is you. In the end of the late summer school, we are sure you will have learned a lot, and you will have had opportunity to network. This is also very important. Sono4U, I want to point out you're doing a great job. And all the best for the late summer school today and the next 2 days. Please remember the Corona rules and enjoy the days at the Medical University of Graz. I will stay tuned online. Thank you.
Thank you very much for your kind words. This event would not have been possible without the tremendous support of our partners and sponsors. First of all, a big thank you to the ÖH of the Medical University of Graz and the university itself for the help in the context of the event and the great cooperation throughout the year. Also, we would like to thank our partners of this summer school. Conventa, who provides the technical equipment, and especially thanks to Lukas Waldhofer, who supports the technical team from above there. The AGN and the Medical Corps Graz are also our partners. Moving forward, we would love to thank our generous supporters, our generous sponsors. So, a big thank you goes to Vorarlberger Landeskrankenhäuser, Burgenländische Krankenanstalt, Steiermärkische Sparkasse, Siemens Healthineers, Skillsmed Deutschland, and die Deutsche Röntgengesellschaft, and the City of Graz. Last but not least, a special thanks also goes to Midas for providing the ultrasound equipment for this weekend. We would now like to introduce Christian Schandl from Midas, who will tell us a little more about the company. Please welcome Christian Schandl.
Thank you. Welcome everyone. My name is Christian Schandl and I'm from Midas Healthcare Technology. I'm the business unit manager for ultrasound, and that's a very big honor for you from us, and to give you the possibility to use our devices to be hands-on with your ultrasound systems. Midas stands for not only to sell something, we want to have an environmental impact from our side. What does this mean? We not only provide our systems, but also have a service and spare parts. Furthermore, it's very important from our side that we have an environmental impact. This means that we do not trash our devices or trash the devices from our customers because we repair it. And therefore, it's very important for us that you know that we have our one-stop shop philosophy. That means that we have devices, we also provide you with service and spare parts, and also the Pro Prepare. And finally, I will give you something from the meters. This means that we are our support in ultrasound. We really thank you for the opportunity to be here today with you, and if you have any questions, you can come to us and ask something about ultrasound. We thank you for this opportunity and wish you a nice weekend. Thank you.
So, as you all have already heard right now, this event was organized by Sono4U Graz. But maybe some of you or some of our listeners via the live stream may ask themselves the question, what is Sono4U Graz? So we are a group of about 40 active students, and we organize different courses and, for example, also this late summer school every year. It's already the 8th edition right now, in our free time. So it's important to emphasize that we are not employed by the Medical University of Graz, and we are not getting paid for our doing. It's simply our passion for ultrasound and the desire to pass it on to our colleagues. Sono4U was founded back in 2013 by a group of very enthusiastic medical students. One of them is also here with us, and the speaker later on, Dr. Simon Orlob. Welcome, Simon. Without the dedication of you and your motivated colleagues from back then, none of this would have been possible. We would also like to welcome our long-time alumni, David Burkharthofer, who is also having a lecture later on. Welcome, David. Most importantly, we would like to thank the whole entire team of Sono4U, especially right now in these days where we have such a lot to think about and to do. Thank you all. And besides Sono4U Graz, there are also some other student initiatives around Europe which we can call our partners, and some of them are also with us today. So from Germany we have students from Witten, Brandenburg an der Havel, Mannheim and Köln with us today, and from Austria we have some tutors in Linz. And some of these partner universities are also organizing some hands-on sessions. So we say hello to all of our partners out there and wish you also nice 3 days, and we hope that you will learn a lot out there. During the late summer school, an idea was born to expand Sono4U Graz offers with some pocket ultrasound devices. Our colleague Anna Tranninger has developed a new concept with the support of David Burkharthofer and other members of the association. This project is thankfully funded by the Flick-Förderungsstiftung. We would like to take this opportunity to thank the chairman of the Flick-Förderungsstiftung, Ea Maria Konrad-Ischeb, for her great trust and support. Thanks to the generous financing, we were able to get 6 devices, including accessories.
No? Is it working now? Okay. These pocket ultrasound devices are a great next step in ultrasound teaching for interested students. You don't need a big machine anymore, you just need a tablet. The ability to acquire and practice hands-on skills regardless of location, time, or a course is something we are very passionate about and can be further developed with this offering. We plan to offer a free and easy rental of the ultrasound devices for all interested students to improve ultrasound skills at home or with their friends. You will find out all further information via our homepage or on our social media channels. Furthermore, an offer is currently being created for students to perform ultrasound diagnostics under supervision, apart from our existing courses. The pocket ultrasound devices allow this teaching unit to take place as a bedside teaching. So stay tuned, and we're very happy to present you this opportunity. Now, we need to also talk about the pandemic. We are very happy that this summer school can take place, but nevertheless, a few words about the COVID rules that must be followed during the weekend. FFP2 masks are mandatory throughout the event. If you do not have one, FFP2 masks can always be provided by us. Please wear the mask during the event as well, and during the breaks. Besides you're sitting on your chair and eating your snacks, then you can take it off. We ask you to use the hand disinfection facilities we offer, especially during the hands-on sessions. Keep a distance of 1.5 meters from all participants, including during the breaks, and be mindful of the entry and exit rules. The main entrance, which is the glass box above us, is only open for registration and the entrance in the morning. We then have to lock this entrance, and everyone else, for example, if you're late, has to use the entrance through Auenbrugger Platz 15, which is the officially clinical entrance on the other side. You can use all doors down here for exiting, but if you want to enter again, you need to go up and use the official clinic entrance again. So, and if you feel sick, please stay at home, of course. If you develop any of COVID-associated symptoms, get a positive test result, or you're a contact person, please inform someone of our team. We will then take the necessary steps. So, stay safe. But now back to the more pleasant part. I will now give you an overview about the late summer school program. Today, we will start with the Keynote Lecture and sonography basics. After that, the first hands-on session is on the program and a lecture about anatomy. Tomorrow and Sunday, we will each start and end with a topic-specific lecture, and hands-on session will take place in between. At the end of each lecture, you will have the opportunity to ask questions either here in the audience or online. You can ask questions on the Sono4U Graz Facebook page, on Twitter, or on our Instagram page. By the way, you can also follow us. On Sunday, we will conclude with a Sono quiz as a small recap. Now, we would like to take this opportunity to especially thank all the speakers for sharing their knowledge and experience with us students. They do this voluntarily and in their free time, which is just incredibly great. Thank you very much for your commitment.
So we will already start with the real program of the late summer school. Our first lecturer has a PhD in critical care and is well known for her commitment in student education in the Netherlands, which is very inspiring. Please welcome Renske Wiersema as our keynote lecturer.
Should I take that off?
Yeah, maybe.
There you go.
Perfect, thank you.
You can use different parts of physical examination to see how you can actually assess your patient, and then the protocols tomorrow are going to teach you is there shock and possible causes of shock. But for that, your physical examination comes first, right? So you feel the patient, is he or she hot or cold, or for example, assess the capillary refill time. And that's actually quite interesting, because if you're going to look at the evidence for physical examination, you may find out that it's quite limited, but it's something that we all learn in our medical degree, at least in the Netherlands, but I hope or think you too, right? Good, okay. So you are doing physical examination routinely for diagnostic decisions, but also decisions about your treatment. And in shock, it may actually guide your treatment. For example, if you give, for example, some intravenous fluids or noradrenaline to get up the blood pressure, you may feel the patient's legs and say, okay, so this patient is getting more warm, so probably the direction of the treatment is going somewhere. But if you're unsure about your diagnosis, ultrasound may help you a lot. And that's why we wondered in our first studies, what's actually the association between physical examination and ultrasound, because that wasn't even investigated, but on a theoretical basis, we use it every day. And that's how the study came up. So it was a very simple study, and that's also why it's called the Simple Intensive Care Study, or the SICS, in a prospective observational nature, completely student-run, to assess the outside versus the inside, using a lot of different people from different backgrounds, for example, specialists, but also residents and students for 24/7 inclusion, also on voluntarily basis, like Sono for You. I'll pass through this a bit quickly to get to the next part, because we started with 6.1, which was the first part of our study, to assess how physical examination or clinical examination may predict the actual cardiac index. So one of the things you're going to be looking at tomorrow as well is the heart, and that's something that I'm the most passionate about of the human body, but you're going to see, is this heart working enough or well enough to provide the rest of the body with enough blood supply, right? And we wondered, perhaps your physical examination, what we always learn, can predict some of how well your heart's actually doing. Because that has been said by expert opinions, and that's what we learn, right? If you're very cold, maybe your heart's not working well, or you're in sort of shock. But that hasn't been investigated, actually. So that's what we did with this study. And the team started to grow, because we started out with 2 students who were very enthusiastic about this. And then there were some other students who had to fill in some creatinine and urine output data, like myself. But slowly, more and more students became interested, because this was research in which you could actually see the patient, get experience with clinical examination, and then, to top it off, perform an ultrasound to see what's happening on the inside. And then first it was all in the hospital, but then we ended up doing barbecues and pub quizzes and stuff, but that's the next part of the story. And the result was that from 2015 to 2017, we included over 1,000 patients voluntarily with structural clinical examination and ultrasound. And we found that low cardiac index was actually present in 1/3 of all our patients. But the abnormal clinical signs that we found could actually identify which patients had such a low cardiac output or cardiac index and shock. On the other hand, we also found that normal clinical signs did not rule out a cardiac index. So that's just a short result of this study. But we learned way more important lessons for me personally than just the results of this study, because we learned that students really liked participating in this study because they need research experience for their resume to get into, for example, specialist training, but also clinical experience, using their theoretical background knowledge, but also be challenged, but most importantly, to have some fun. And that's what we had. But then back to the 400 creatinine values that I entered, because that had to come up back somewhere, right? It appeared that 50% of those was abnormal in our patients, meaning that over half of our patients had some form of kidney injury. And so that's when I decided to get more into this research and further use ultrasound to see if we can actually elucidate why so many patients of us had acute kidney injury. So really short, it happens in over 50% of critically ill patients based on a rise in creatinine and a decrease in urine output. But the exact role of hemodynamic function is unclear, because you can imagine that not all these 50% of these patients had shock, but still, most of them got acute kidney injury. So how is that possible if we think that acute kidney injury in critically ill patients is due to shock? And that's what the Simple Intensive Care Studies 2 was about. So we needed a new team with more and more students, but as we mentioned that we were going to do ultrasound and teach each other clinical skills, we found a lot of students very quickly and we were able to get started. But we had a new aim because we learned some lessons from the previous sessions, and we would actually like to give students more responsibility in getting their own research question, therefore being more invested also in finding the answers to these questions, having fun, getting their European study credits, but also having an adequate sample size to answer our research questions. Also, when you have a large number of students involved, you have some challenges because we have a large team of unexperienced researchers with limited clinical knowledge. And that you need some time to gain the skill. We're going to try to do ultrasound, the full examination in 3 days this weekend, I believe. But still, you also need experience and time to interpret what you see and think, is this normal or is this abnormal? And lastly, you need funding mostly. And what you guys already mentioned, you have a lot of sponsors, so well done for that. But sometimes it's very difficult to find the appropriate amount of money needed to do these type of projects. So what we did is we created a protocol which would be open and online and free available for everyone in a PDF version, but also in a video protocol, so that it would be very accessible to all the students who would like to participate in our research. And we published that in a journal of visualized experiments. So maybe it's for later, but I posted the QR code for myself. So if you guys would like to see the video after you've done the sessions of tomorrow and today, I'm pretty sure with what you're going to learn, you'll be able to get our protocol as well. But most importantly, just like we're doing this weekend, we had frequent ultrasound training with our experts, cardiologists, radiologists, but mostly our students and myself. I'm here below in the in the thing because you need to be somewhere, right, when you're teaching your students. So that was very nice. And we're trying to get the vena cava in the picture here. But also a lot of fun thing. So we needed money, and we usually spent it on the equipment we needed and sometimes on a pub quiz, which is good for team efforts because we did 24/7 inclusion, so that meant that some of these people had to go back into the hospital the morning after to do the ultrasounds. So yeah, you can doubt about the professionality of that, but I'll leave that out of place. One of the other issues I mentioned with students doing ultrasound, because I'm all up for students doing ultrasound, otherwise I wouldn't be here, and I love doing ultrasound myself as well. But we need to also be very aware of our own limitations. That means that sometimes you're not sure of the image, you're quite inexperienced, so you need to recognize when do I not know what I'm seeing and how do I call for help. That's also the case for the simple intensive care studies, because we needed to make sure that the images we were getting were actually the appropriate images and the appropriate measurements if we were going to publish about it, saying, well, if you see this, then it must be that. And therefore, we made sure that we had some experts who would all in their free time check our images. So we had a cardiologist, a radiologist, and a core lab, immediately also giving us independent validation and also unbiased, because they wouldn't see the patient. We would have seen the patient, so we already knew if they were very sick or if they were cold or everything, but these people wouldn't. So therefore we had kill two birds with one stone, I think is the appropriate English expression. And we were very thankful for these people because they helped us to get the good images. But more importantly, they also give us feedback. So sometimes they noticed, hey guys, when you're doing the apical 4-chamber view of the heart, when you're trying to get the vision of the 4 chambers, which it says at the thorax, we see that you guys have a bit of a foreshortened image, meaning that the angle is not appropriate enough, and that would complicate probably some of our measurements. So in that way, we could also evolve into having better quality of the images themselves. So the result of this second study, in which this was really my study, so to speak, for my PhD personally, we included over 1,000 patients again, so 24/7 in the weekends, in the nights as well, and that made that we could include over 1,000 patients within a year. So that was very nice to be able to manage our sample size in that quick amount of time. And we looked at 2 different things. So we looked at the incidence of AKI, which I mentioned, the creatinine values. But we also looked at the clinical examination. Can you use the clinical examination, so what you see on the outside, to predict what's going on? But most importantly, we looked at ultrasound. How can we use ultrasound to elucidate which of our patients, how many of these 1,000 patients get a good kidney injury? The most important thing I learned from this study is that while I was doing all my statistics, the first part of going into assessing is there an association between AKI and, for example, inferior vena cava size, I needed to see how many people actually had acute kidney injury. And this picture may look a bit difficult, but it's actually quite simple, because I ran into the fact that people use every definition for acute kidney injury differently. So I noticed this when I used appliance A, I got a definition of, or an incidence of AKI of only 27%. So I thought that's much less than the 50% I had in the previous cohort. But then I saw a different study who used a different approach to the same definition to define if someone has acute kidney injury or not. And then I ended up with incidence of almost 80% in the same cohort. So that's what really, I was really intrigued. So how does this work? How can I, in one cohort, found such large differences in incidence using the same definition? And it's all based on interpretation. And I was really in doubt because I thought probably some people have to have run into this as well. So do you then choose what fits your beta test? And I was conflicted by that, but I went up to my professors and said, people must have this same issue because I'm not the only one investigating this. This happens all around the world. And then we decided, or we asked if it would be possible to try to show this problem and actually get it published. And I think that's one of the most important results from the study is that we try to look between associations X and Y, but it already appears very difficult to define X or Y, so always be careful of what you're looking for. And that the incidence is very different depending on what definitions you use. And that's something that's very important to keep in mind for this weekend, because now I'm sharing this in terms of acute kidney injury, which probably doesn't bother you at all because you're here for ultrasound. But what does bother you is the ultrasound itself. But also be aware, every time you make an image or you use, for example, the RUSH or the FAST protocol, it's all about the definitions. So be sure to not be blinded, to look at a problem or at your ultrasound from all kinds of different angles before you make a conclusion and write up what you find. But the other purposes of 6.2 were to look at the differences or the associations between clinical examination and acute kidney injury. So can you predict from the outside, for example, if you don't have an ultrasound, if someone is at higher risk to get acute kidney injury? And we actually found that besides the usually known risk factors, such as age, we saw that subjectively cold temperature, so simply touching someone's legs, but also a prolonged capillary refill time at the sternum actually increases your chances of having acute kidney injury, even when being corrected for other risk factors. So showing that your clinical examination is evidence-based, actually good for something, so keep doing it. But then the most important part, we were looking at the ultrasound. Then we need to dig a bit more deeper into the pathophysiology, because I noticed, and I also explained a few minutes ago, that the thought about acute kidney injury, so a short term of decrease in renal function, was due to shock, which is something that you're going to focus on a lot tomorrow as well. But as I mentioned, we noticed that a lot of people who actually had it didn't have shock. And we figured out this model, which has been going in literature as well, but wasn't really investigated yet. And that means that if you look at the top, I hope it's graphical, but I hope it's clear what organs are which. You see that there are various factors which may, in critically ill patients, influence renal function. Starting at the top, you have the left ventricular function, which is needed to get enough blood pressure to get the blood perfusion to the kidney. But also the right ventricular function, because if you imagine, if you have a congested inferior vena cava, the renal pressure goes up, which causes raised interstitial pressure in the kidney itself, and that, in the end, also compromises renal function. So you can imagine that forward failure or shock or a decrease in left ventricular function due to all sorts of reasons can give AKI or AKI. But we figured probably this backward failure, which you're I think aware of because it's also in textbooks, might also give rise to acute kidney injury. But this wasn't investigated using ultrasound yet. So we tried to see, can we actually use ultrasound to envision all these things on the chart and then see if that actually is the case. So do people with a congested IVC, with a decreased RV function, and with increased tubular pressure get acute kidney injury more quickly? In that case, we could actually use it to seek out the high-risk patients and make sure that they were off every nephrotoxic medication that we would know. So what we did is a lot of ultrasound, a lot of scans, and we started at the top left. What do you guys think you're seeing? Starting with an organ, what would it look like? You guys, maybe? So at the top, you start with a pleural line. So what would the bottom be? Yeah, the lung, yeah. So what we're looking for is pulmonary edema, and this is something that you'll get back to on Sunday with Johnny Wilkinson, my colleague from Great Britain. Because if you have pulmonary edema, or what you listen with your stethoscope, that may be a sign that you have too much fluid in your system, so much that it can actually run out of your lungs. And that you can see in here reflected as B lines. So the lines horizontally are the lines that you should have in your lung, and the lines vertically are lines that you shouldn't have in your lung, which represent fluid in the intrapleural space. Second image, what do you guys see? Which organ? No guesses at all? You're gonna have a tough weekend. Okay, so this is the heart. And what you see is that it's moving. Is it moving a lot, or is it not moving at all? It's moving a lot, right? It's quite enthusiastic, I would say. Especially if we're gonna compare it to this one. Which one would you say has cardiogenic shock, and which one would you say has septic shock? Everyone who says that this is septic shock, hands up. Cardiogenic shock, maybe? Yeah, that's right. And how about that one? The septic one, right? Because what we see in septic shock is a very different pattern than in cardiogenic shock, which the heart tries to compensate for the extremely wide vessels overall in your body, trying to get enough perfusion as possible by working very, very hard. But also in the end, if you don't treat this, you will end up with this as well. But depends on what time you look at it. The last one. Any idea what this is? Yeah, and which valve would you think it is? So it's correctly, it's a valve regurgitation. So that means that, you know, this blue line moves away from the probe. The probe is at the top. So that means that blood is actually going from the ventricle to the atria, which is not the way it should be moving. But the thing is that this is actually in the right ventricle, and that's what I was referring to you in this image. If you look at decreased right ventricular function, a measure of a decreased right ventricular function, or RV overload, is actually the regurgitation of the valve. So the tricuspid valve isn't made to withstand large amounts of pressure, because it's made to just be a door opening simply from one place to another. But if you have a lot of fluid, which is something that we might do in critically ill patients, you actually get regurgitation. So that's what we see in the last one. But then we also wanted to look at the kidney. So this is something that I think isn't in the program for this weekend, but just very short overview. This is the inferior vena cava, and what you see here is that we're trying to assess whether it collapses to assess fluid status. And then you can actually envision the kidney very easily and see the perfusion. So that's something you can measure as well, which is shown here. So the results of the simple intensive care studies 2 was actually based on acute kidney injury, so it's important to choose the right definition, or at least be very transparent in your publication about how you interpreted your definition. But it's also a very, very complicated disease, and it's not just one thing, which is what I thought when I was starting my research. But more importantly, especially for this course, is that ultrasound can help you, in this case in acute kidney injury, but in many other diseases, I think. For example, by estimating cardiac function for an assessment of cardiorenal syndrome, assessing fluid status for optimal management. Should we actually give diuretics, or should we push more fluids in these patients? But also, if, for example, in this specific case, excluding the post-renal calls as so that would be to make sure that you don't have congestion around the kidney itself, hydronephrosis. But in the end, this led to a project which had 0 funding, ran over 4.5 years. Over 30 publications, mostly open access, because we find that very important, just like you guys here. But over 50 students who performed an internship of 6 months full-time in research and clinical experience, with over 100 students in a voluntarily team who also got in at night to see the acutely admitted patients. Over 1,500 European student credits earned with this study, and over 2,000 patients included. And this was all done by a team of medical students, but in the end, even pharmacy students who learned about this experience and they were so enthusiastic, but also nursing students. And this has one very big additional pro, is that you can already learn early on in your education to cooperate with other people in the medical profession, because that's in the end how you're going to take the best care of your patients and have fun while working in a team. I think that we used this structured non-funded research registry to be able to have such a high inclusion rate, and I think that doing things starting from enthusiasm is what makes it last. So I think that Graz is also a living proof of that as well. And I wanted to end a bit with how, in that case, did I end up here. It all started with the 400 simple creatinine values that I had to enter into the computer, and then ran into this very weird incidence. But that made me join a team in which I learned ultrasound and got connected to other people who were enthusiastic to ultrasound, and eventually managing or coordinating a new study in which we used ultrasound to connect students with each other and learn each other and how to assess these patients. And in the end, that made it very possible for me to finish both my PhD and my MD in quite a short period of time. So I started at the University of Groningen, and using all these projects, I ran into London. I graduated today from Harvard, so I actually missed a bit of my graduation session for this session. But the most important thing is through these efforts with the team. So it's just me standing here, but that's only because we worked in a team very hard. We made over 1,000 scans, and that's something that helps me now when I work as a doctor in cardiology. Actually helps me every day, because I have a lot of experience already. So you can't start young enough with doing ultrasound, or even do a PhD in it, because I really had a lot of fun. So it's a good tip for everyone. And I'm very enthusiastic to, just like me, just start early on with doing what you like. And I'm going to ask that later, because that's also actually what I wanted to end up with the most important take-home message for this entire weekend. I think everybody starts somewhere, everything starts somewhere, and at the beginning you can't really realize or see if it's going to end up into something, but you got to start somewhere. I only shared the things now that led me to being here, but while I was doing the 400 creatinine values, I also did 6 other things which ended up being nothing, but it might as well could have been one of those things that got me here in the end. And do what you like, because I think that if you do something because people think you should do it, or because you want to get into some sort of job, or you have to do it for your resume, you're not going to end up having fun. And in the end, if you have fun, that's what other people see also during job interviews. That's what drives you, and that makes that you're able to do all these things and also keep it up. While also saying, this is something that I learned in the past years, there's always, in every job, there are some things that you don't like and that you just have to accept. Try to get it in the 80-20 position. The 80 being the percentage that you like, of course, at least for me. But also try to find someone in your environment who can offer you some sort of mentorship. For me, this was Professor van der Horst, who challenged me to think about what I would like to do and offered me ultrasound and physical examination as a capstone to get where I am today. So find someone, which can be anyone, doesn't necessarily need to be a professor or a medical director or whatever, but just someone who challenges you to think about, what am I doing now, and am I even liking what I'm doing? And for some people that can mean a PhD, for other people that can mean, I don't know, start gardening or something. I also enjoy gardening very much. So it doesn't necessarily need to be something that needs to end up on your resume for a job. But if you do decide to do something, invest in what you commit to. So that also goes up for this weekend. You're here now, try to make the most of it, enjoy it. But if you're not enjoying it, if you're just doing it for something else, then you can also just do something else that you'd rather do, right? So then just leave, or, well, that sounds very unfriendly, but I hope you guys know what I mean. You're here for yourself, that's what I mean. And not in the classy way, like, so make the most of it, but really, if you don't like it, then if I don't like it, I'm going somewhere else as well. So just choose a bit sometimes. But most importantly, communicate and be honest, because I did have some ideas with when I ended up with the incidence being 20% or 80%, I knew that when I chose the incidence of 80%, my results would be way less better and very hard to publish. But if I would use the 20% incidence of my cohort, I would be quite sure that it would get published somewhere. And I'm very happy that in the end I chose to be honest and present all the things that I found. And now in every paper I use 5 different incidences to prove my point. So that's also, I think, a very transparent way of handling these issues. And I think that in the end, it was quite hard to make that decision. I'll be honest about that as well. But in the end, I'm very, very happy with the decision that I made. And I think that that's also something that takes you very far, no matter where you go. So I would like to thank you all for your attention, but enjoy Graz. And I was also very interested in how you guys ended up here, because I ran into ultrasound through this weird way, and then I met some Sono Graz people at conferences, and now I'm here. But I was also very interested to learn how you guys ended up here, but maybe that's something for during the break and during some snacks. So if you have any questions about this weird road trip along my past 5-6 years, then I'll be happy to hear. Thank you.
So thank you a lot, Renske Wiersema, for your lecture. Now, are there any questions from the people here or from online? So here you can see again your this one. Thank you. And this year we also have a great new possibility, so you can actually evaluate the lectures right after they have been presented.
Oh God.
So
be honest, please.
just take your smartphone, if you have one here with you, and scan the QR code so you can actually give some evaluation for Renske. And in the meantime, if there are any questions, Lorena will just go and collect some interested questions. In the meantime, I would have a question for you. So you said that your students also tried this POCUS systems on this point-of-care ultrasound. In which scans did they actually had most troubles with, and what tips actually you gave the students then to go on and not to get dispirited?
Yeah, so I think that's a very interesting question. For those who didn't hear the question was that a lot of our students did a lot of ultrasound, and what did they find the most challenging, if I understand correctly, especially in types of scans. I think the most challenging for people was still cardiac function, because the cardiac people tend to forget that the heart is just a flappy sac lying around somewhere in your thoracic cavity. So that means that if you agree to start, for example, with the peristernal long axis, which is something we'll get into tomorrow, some of you guys perhaps already know, but that sometimes you don't always find what you're looking for. And I think that as anatomy, which is something that we're learning about later today as well, was very different for every people, especially in an ICU. Optimally, you're going to notice that tomorrow as well, you'll have patient positions on their left side to make sure that the cardiac structure is pointed towards the thorax, and it's easier to see, because the closer you are to it, the more easy it becomes to see. But in intensive care patients, you know, some of the times they're on the tube, or they're very sick, and you're a student, so sometimes you're not comfortable enough with making sure that they're in the right position, or you don't want to change their position because they are so sick. And that makes it sometimes very challenging to actually see the proper images and get the right measurements. Yeah.
All right, thank you for the answer.
Any other things?
Any other questions?
Was it a bit fun? Because you're all like, I know it's Friday afternoon, but Okay, good. Well, thank you guys.
Thank you a lot for your presentation, and we have a little present also here for you.
Thank you very much for your nice lecture. It was very interesting, I guess. You can go down there. There's a stair. Yeah. Okay, now some organizatory details also. Some people haven't been at the registration yet, or if you don't know your group yet for the hands-on sessions, or if you don't know your group for the clinical visits next week, which will take place in the hospital, please come to my colleague Katharina Hinterhölzel. She's at the entrance at the registration. Yes.
Perfect. And if there come up any other questions also regarding the clinical rotations, then in the next upcoming week, just ask some of our tutors. And so before the next lecture, we will actually have a little break until 5:15 p.m. so you can actually got a little snack what we brought to you. And we will also show on the screen afterwards another QR code, and this QR code is the so-called pre-test, so that we offer a possibility for you and also for us as an initiative to see how you changed over these 3 days. So if you got a little bit better, or what were some problems with, and so on. We will just show it right now, this half an hour. And so we would like to ask you just to scan the QR code and then to make this pre-test, so that we can start all with some basic knowledge. All right, so we will see us again at 5:15, and in the meantime I wish you a nice little break. Yeah? Maybe on the big screen. Okay, yeah. This problem? Okay, we will try to solve the solution, find a solution, and we will just at the end of the break we will show it again for Renske. In the meantime, we will show the QR code for the pre-test. Is it okay?
Are there any other questions? Okay, then enjoy your break and see you later.